This program is brought to you by Emory University.
Well, good morning, everybody. I think we're probably going to get started here. So thanks, Pooja, for having us today. So we've got a really interesting talk here. I think it's kind of a new topic for a lot of you guys on the phone call or on the Zoom. At one point here, we were going to talk about pre and post CABG intervention too, which I think is a really interesting topic. And Dr. Sperling had some recent experience with that I think we've kind of inspired a little bit of discussion. But today we're going to focus on complex coronary revascularization with intervention, particularly in the drug-coated balloon era, which is a new process kind of sweeping through our interventional experience, where you're going back to the days of early angioplasty, back to the 80s, where we're not putting a scaffold in, where you're just doing a balloon angioplasty result, and then you basically are painting the vessel with medication at the end of the case. And so you're doing all the intervention and then just doing the drug-coated balloon for a 30 to 1 minute and 30-second inflation to try to deliver drug, and then going away without any kind of metal, which is going to change the whole paradigm, because it's going to take complex bifurcation stenting and make them simple one stents, or maybe no stent strategies. All these kind of full metal jackets you hear about in the right, or the LAD that preclude somebody from having bypass surgery, are going to go away. And so, I mean, I think you're really going to see where this becomes not, an option as an alternative to other revascularization strategies. I think it will become the primary first choice. I think it, and so really what we're trying to figure out is how do we prevent acute thrombosis, and then deal with what the restenotic rates are going to be down the road, which are looking good. But this is new in the U.S., and we're really sort of taking the lead charge here at Emory with some things we'll talk about at the end, as far as positioning us well to be kind of the pioneers for this, which we should be, since Emory's where balloon angioplasty was invented anyway. So always nice to have everybody with us here. Prathik Sandasar really needs no introduction. Prathik runs our program down at Midtown's busiest operator in the program, has the best outcomes in the program as well. He's in the top decile for nationally in the NCDR for his performance, which is just outstanding. He runs the clinical research division for us as well. Just been a huge asset since he came on board a few years ago. Nice. Firas Dabai, I think you should all know him by now. Firas did critical care and then did interventional cardiology, and now is doing a chip year. So Firas is incredibly well trained. We're fortunate he's going to stay on board with us starting in July. He'll be splitting his time between the cath lab and critical care. I think you're doing 75% cath lab, 25% critical care, if I recall correctly. But excited to have him. And then Javier Farinas, who's a really great operator with us. Spent last year doing his interventional year. He's doing a chip year this year. And he's going to go back to his hometown in Miami, University of Miami, in July, or probably start in October, but he'll finish here in June, then take his requisite 4 months off. But he's going to take over a program down there. Miami, the whole Florida area, there's a paucity of really high-end complex coronary work being done. So he's got a really big opportunity to go there and make a big impact. And so he's going to be great for us too. So they're going to talk a little bit about the data, some cases. We welcome interruption. I mean, it'd be a lot nicer to have discussion than just us talking the whole time. We'll try to pay attention to the chat and see if anything comes through that. But I'm going to let Firas and Javi take it over here and get us going.
All right. Hey, everybody. This is Firas. So get started. We don't have any financial disclosures. So we're going to talk, the objectives for this talk is to explain the pathophysiology of antiproliferative medications and coronary intervention. Then we're going to present a couple of cases, and then we'll talk about the data behind drug-coated balloon technology. And so really, this is the evolution of interventional cardiology. Started in 1977, where Andreas Grunzig did his first PTCA and came to Emory and made it mainstream around the world. And after that, we had some limitations with balloon angioplasty, which required the need for scaffolds to keep lesions open, prevent lesion recoil, and some problems with dissections from balloons. And so the bare metal stents came about in the late 80s and were mainstream in the 90s. But the Achilles heel of bare metal stents was in-stent restenosis. And so there was a need for an anti-proliferative medication to be added to these stents so that we don't have that problem. And that's been going on since the early 2000s until this date. But lately, we've been looking into, do all patients need to have metal left in their bodies? And so Europe has been looking into drug-coated balloons in the late 2000s and the early 2010s, and became mainstream over there over the last 10 years. We're a little bit behind Europe in that, but we've been starting to have some drug-coated balloons in the last couple of years. And so first I want to explain, when a patient gets a balloon angioplasty, there's inherently endothelial damage, and that causes inflammation, platelet activation, cytokine release. And that really activates the vascular smooth muscle cells in the media, and they migrate into the intima. And after proliferation, you get a neointimal hyperplasia, and that's what drives incident restenosis or just a lesion recurrence if it's a balloon angioplasty alone. In that context, the endothelium is somewhat protective in the sense that it releases nitric oxide and prostacyclins and other factors, but the culprit is usually the vascular smooth muscle cells. And so the anti-proliferative medications that we're using are either paclitaxel or sirolimus or one of its cohorts. And so they're both great medications and have some characteristics of their own. So paclitaxel is cytotoxic, works on the M phase of the cell cycle, sorry. And then the sirolimus is cytostatic, works on the mTOR-C1 inhibitors. Paclitaxel is non-selective. It works on both the smooth muscle cells and the endothelium, whereas sirolimus is more selective. And paclitaxel is narrow in its therapeutic window, whereas sirolimus is wide and a little bit more safe in that perspective. However, where paclitaxel shines is that it's very lipophilic and it's fast to be uptaken by the tissue, and it resides there for a long time. There's a lot of retention and it releases over time pretty well, whereas the sirolimus is more hydrophilic and it washes out from the tissue pretty easily, and it needs a carrier to trap it in the tissue and maintain sustained release over time. And so the contemporary drug-eluting stents that we have are all limus coated. We haven't been using paclitaxel drug-eluting stents for a while. And so the concept of a drug-coated balloon is the best of both worlds. We do a balloon angioplasty, we apply the anti-proliferative drug to the area locally, and that suppresses neointimal hyperplasia and restores the vessel physiology without having any metal left behind. And the rationale behind that is that if there's no metal left behind, then we don't have thrombosis, less likely to have neoatherosclerosis inside the stents and multiple layers of stents, and potentially enables a shorter time of DAPT, up to 1 month mostly, instead of doing the 6 months to a year when we have stents. So next, we're going to show some cases. This is our first case. We have a CTO PCI of the proximate LAD. This was a 72-year-old male that came to clinic complaining of exertional dyspnea, had some coronary atherosclerosis by coronary CT and hypertension. He was on some good medications, aspirin, rosuvastatin, and nifedipine. And his ejection fraction was preserved by LV-gram on a diagnostic cath. And this is our CTO intervention. So we have dual injections over here, and you can see in an REO crani projection that the LAD over here is a CTO, and it fills via collaterals, septal collaterals, and collaterals from the right side. Let me go back. And this is the only left side injection, and the CTO is a little bit more evident over here. And so the first thing we did is we wired the septals with a whisper wire, and then we got a microcatheter. And what we do in these cases is that we try to inject the septal collaterals to see if they connect to the vessel distally. And if they do, most of the time we're able to get our wires through those septal collaterals. We do this also when there's a right to left collateral or a left to right collateral. And so when there's a connection, we use some soft wires like the SUA wire or a Xeon black wire, which is polymer jacketed. And we were able to, with some technique and some patience, we're able to get these wires to kind of traverse the septals pretty safely. And we can go from right to left, or from left to right, or in this particular case, we can go from left to left through the LAD. And the advantage of that is that when we get the wire to the distal CTO cap, usually this distal CTO cap is less calcified. It's easier to traverse true to true lumen and retrograde. And if that's not possible, then we can also do a controlled antegrade and retrograde dissection. That's what we call reverse cart. And then we're able to get into the true lumen. In this particular case, we were not able to go through the septal collaterals. I just wanted to show that technique that we usually do, but we were able to go antegrade pretty easily true to true lumen with a Pilot 200 wire, which is our specialty wire. And you can see over here that this is the CTO segment, but then the vessel distally has some diffuse disease over here. And so We ended up putting a short stent, a relatively short stent, about 26 millimeters in the proximal part. A couple of years ago, we might have needed to stent the whole vessel, had 70 to 80 millimeters of stent over there. But now what we decided to do over here is we treated this area with smaller caliber balloons. And then when we had a good result, we actually did a pressure wire, and we found out that there was not a lot of flow limitations, borderline DFR, and we were happy with that result. And so we ended up doing drug-coated balloon treatment to that area. And this is our final result. And the nice thing about this is that now this patient has a shorter stent over here. You have a very good result distally, didn't need a metal jacket of the LAD, and that doesn't take away a Lima prospect in the future should he need that later on. Our next case is a high-risk diffuse LAD disease, which we see quite commonly. So we have a 72-year-old female with ongoing exertional dyspnea, has a history of CAD and an RCA CTO in the past with a stent in the LAD. Ischemic cardiomyopathy, EF is about 35 to 40%, on all other comorbidities, including diabetes and peripheral arterial disease. And so she's on some good medications over here. Her EF is 35%, and she had a cardiac MRI that showed non-viable scar in the CERT territory, but the LAD was preserved. And so, I mean, this is her films over here. You can see that the calcium of the LAD shows up even before the angiogram. So she's severely calcified all throughout the LAD. Pretty horrible disease from that perspective. Obviously, she was seen by surgery, and she was turned down. So the only option over here was a intervention. And so this is a quite complex case. When we have a low EF, you have a CTO on the other side and a LAD that needs to be, the calcium in it needs to be modified throughout the whole vessel. And so we ended up putting an impella for protection. And we did a rotational atherectomy. This is our burr. The smallest one we have is a 1.25, and we went modified all that calcium from the proxidistal LAD. And then we had a good result. You can still see some disease over here, but we had some improvement with the flow. Next, we did upsize the burr to a 1.5 millimeter burr, and we also did atherectomy throughout the whole vessel. And after that, you could see that we had much better results over here. There's a little bit of a dissection of the vessel over here. You can see that lucency in the lumen. And so we ended up treating those areas with non-compliant balloons. And after that, we did a pressure wire of the vessel. I'm going to talk briefly about this. This is our technique. Usually when you're doing a pressure wire, these are stiffer wires than usual. And even if they weren't, we don't really like to have a wire go through a dissection plane. And so we use a dual lumen catheter where we deliver the wire through that catheter distally so that we don't have to go through the disease. But we have to zero first in the proximal part. And so here you can see how we zeroed over here. Then we retract the wire into the dual lumen catheter. We deliver the whole dual lumen catheter down distally, and then we retract the dual lumen catheter out. And then we do our DFR measurement. And it was quite significant over here. So we did some more balloon angioplasty. And then we treated the whole vessel with drug-coated balloons. We didn't deploy any stents. And so the longest balloons that we have right now are 30 millimeter balloons. So we used 3 of them. And this was our end result. Still some disease, but that's a pretty sorry. And then that's the post. And so you can see the difference between pre and post. Still some dissection over here, non-flow limiting. We watched the patient for a couple of minutes, and she did great. She actually came back on Friday for a RCA CTO, and the vessel looked identical, the same as we see it over here in the post.
Right. So, I mean, this is a great example of cases where, you don't really have a place to put a Lima and just severe calcium. I mean, these are cases where, a lot of times patients would get full metal jackets. I mean, I think the fact that we're able to treat her entire vessel with just drug-coated balloons and not leave any metal behind. I mean, I think this is it can be a really nice way to treat a lot of these patients with diffuse disease, which we see a lot in diabetics and a lot of the patients in our practice here, especially down in the South, day to day. So I think this is a really nice example of the utility of drug-coated balloons, and probably one of the more extreme cases of what we can do.
It is, and this is where it's going. I mean, you're gonna. I think in 5 years, I've said it before. I think we'll stent less than half the cases that we do, and I think the big fear in these cases is going back to like the original days when you hear from, John Douglas and Spencer King and the guys who pioneered this was the fear of acute closure, because that's why stents really came about, was because you would do the modification, you end up with a dissection in the vessel invariably. You almost always have a dissection, and they can get scored on kind of how severe or how threatening those dissections are. But those used to go upstairs or go out to the floor and then acutely close in the first 12 hours, and you're back in the cath lab with a heart attack at that point in time, obviously, and then a certain percentage of those patients went to emergent bypass surgery. And I think the paradigm has changed quite a bit. We're not, when you look at the data from Europe now, the big opportunity in this is nobody's really taking the charge on trying to figure out what's safe in that first 24 hours, and that's kind of where we're focused on at Emory with some things I'll talk about in a little bit. But I think if you can avoid that first 12, 24-hour acute closure, you're past the window then. And so then those patients do very well. And there's evidence back from the day that, if you had a dissection that did not close versus had an angioplasty without a dissection that did not close, the person with the dissection healed and did better than the person without. So I think you're going to see things switch here entirely. And I think you're going to see a situation where, bailout for the old days of angioplasty, because there was nothing else with surgery, bailout for this is obviously just going to be going back to stenting, which is not a big deal. But you kind of wonder, like, when you're going to have these situations, and if you take away the acute closure, you haven't left metal behind. Why would this not always be the first choice of revascularization for everybody? And you're not changing any of the downstream opportunities, and you add on to that to the fact that we get so many complex cases that are turned downs from surgery. Like, I mean, the anatomy that we're dealing with is the most complex anatomy. The simple stuff the surgeons want to do, the complex stuff that gets sent to us. And so this is going to fit that kind of simpler crowd even easier. I mean, because I think you're going to have less concerns in those cases. And so it's going to be an enormous change with where we're going. And I think you're going to see also bioabsorbable scaffolds come back into play over the next 2 or 3 years. And so I think you'll even get situations where maybe you'll do a hybrid revascularization of the vessel, where you do a lot of drug-coated balloon, and maybe put in a short bioabsorbable scaffold that'll be gone in a year's time. And so it's getting better and better, and I think it's all going to be falling in our purview. So, any questions about any of that? We're going to go over some other data here, but I don't know if anybody's got thoughts or questions.
Hey, Bill, Pooja asked a question on the chat. She asked about whether patient needs to come back in 1 or 2 years for repeat DCB electively, or is it supposed to last?
Yeah, it's a great question. So yeah, I mean, you're doing this. So if you think about the mechanisms of restenosis, I mean, the stent has nothing to do with that, right? I mean, the stent helps prevent acute closure, early recoil, and the medication then stops the inflammatory process of the smooth muscle cell proliferation and in-stent restenosis. So if you think about what you're doing minus the stent here, so you're delivering medication at the time, so you're getting that first bolus upstream to stop inflammation and stop smooth muscle cell proliferation. So that's the treatment for the restenotic effect. And then, if you don't have acute recoil at the time and you get some with paclitaxel, it's nice, you get some late lumen gain, like the vessel actually continues to grow over time. So you don't have that, and then you take away the acute thrombosis, which is really what the stent was nicest for, or designed for originally, was to prevent acute thrombosis. And we think we have criteria that we can predict who's not going to thrombose afterwards. And there's data out there that it's looking very, very promising, like less than 1% acute thrombosis, like much less than 1%. And a lot of those cases in ACS, it's been looked at in Europe. It just hasn't been looked at in a systematic fashion that we're trying to do here in the States. So if you think about all that, you should have a better situation down the road than what you have with stents. And I mean, with stents, there's a typical, 5 years, there's a 95% patency rate, but there's a matriculation of stents continuing to fail every year for a certain percentage. And so that's why people are looking for alternative options. So in my mind, you might early on in the development of this look at doing angiograms more on a routine basis. And I think we're getting a photon scanning CT scanner, which is going to be awesome. I mean, I think you'll be able to see a lot of this stuff on CT angio as well. But my thought would be that you would not be coming back to retreat. I mean, this would be the equivalent of a intervention as it is in today's day and age. You just don't have the metal behind at the end years down the road.
And the second question was the duration of DAP. How does that change?
So the duration of DAP is actually very interesting. So it's all the trials with DCBs require just a month of dual antiplatelet therapy. So you don't have the fear, like if you think about why DAP got extended back in the day, when we had Cypher stents and Taxus stents, we had these super late thromboses that were coming back at a year or 2 years after the stent was deployed. And it's because you weren't either modifying the vessel properly to begin with, you weren't sizing the stent well enough, but more commonly, you had inhibited so much of the inflammatory restenotic process that the cell struts never got covered. And so there was just metal exposed. And so as soon as you stopped the dual antiplatelet therapy, the platelets got activated, stuck to the stent, thrombosed, and caused a mess. There's no stent there now. So we don't have that with this. So it looks like a month is all you really need from a DAP perspective. And that's based on, I don't know if Mike McDaniel's on the call, but Mike knows more about platelet inhibition than anybody in the program. And I think, when you talk about this, like with ACS cases, those are the times. So we're typically doing a month of DAP for almost all of our cases, in general right now with stenting, regardless of complexity. The only thing that changes that duration for me, at least, is the presentation of the patient. So if it's an elective case, it's a month for me. If it's a ACS case, it's going to be more 6 months to a year to me. But that's not necessarily the case with drug-coated balloons, because there's a lot of data out there with just doing 1 month for ACS cases too. So it should be a real nice strategy, especially for your higher bleeding risk patients as well.
Bill, this is Khusro. I think you're catching up with the peripheral experience for past 15 years. I've been a proponent that there shouldn't be any stenting below the inguinal ligament. And to be honest, I think it's the technique which we will have to train physicians how to do proper balloon angioplasty so you don't end up with bad dissections. And we have found, I've rarely put in a stent below the inguinal ligament, even in complex CTOs and long lesions. And those patients, if they are treated properly, and that's the lesion preparation, then really a drug-coated balloon. And a few times when we have had dissections, those dissections heal up very nicely with drug-coated balloon. And I think the same experience we're going to find in the coronary world.
I think you're spot on, Kuzro. I think that's exactly what it's going to be. And I think so much of what you just said is what we're trying to figure out is taking, if you're under 60 years old, you never did balloon angioplasty. So so really, that's like 80% plus of the interventionalists out there have no experience with it, because, you basically came through in the late 90s when stents came out, and drug-eluting stents came out in 2004. And so anybody who's, under 60 years old has just been stenting everything their whole career. We've been paranoid about leaving any little edge dissection, any tiny dissection anywhere we had the stent. Well, that's just not the case. And I think we're going to have to learn how to do balloon angioplasty like you described, and I think it's going to be a really interesting process. But if you can get away without, I agree with you. You can get away without putting metal, we have a huge advantage of where we've been in the past.
All right, so we got a couple more cases to go through.
Okay, sorry.
No, go ahead.
It's Peter Block.
Hey. I think you muted yourself, Peter. But
We still can't hear you.
I can't hear you.
How about now? Can you hear me?
yeah,
Sorry.
we can.
My apologies. Okay. So I've got a big bucket of cold water here. I'm gonna throw on some of this, if you don't mind. Okay, since I'm more than 60 years old, I was actually around when all this began. And I set the record straight. The first angioplasty wasn't done at Emory, guys. The PR has turned that around a little bit, but the history is that took a little while to happen. But high grades to Spencer and John for bringing Andreas over and making it really the center where everybody came back in the early 80s. That's sort of a sidebar. But the short version of this is, in the 77 and 78, 79, when we all were starting this business, the acute closure rate at that point was somewhere in the range of 60%, and people went off to the OR. And you have to ask yourself, well, why did that happen? And the answer is because everybody had a dissection and dissections, and we didn't know about antiplatelets and all that other good stuff. But having said all that, the fact of the matter is when you do an angioplasty, you don't just push the vessel open and everything looks terrific. You always tear the vessel apart if you do it properly, and particularly if there's atherosclerotic disease there. So my sort of query to myself has always been, if that was so bad back then, why is it that we're so much better now? And I think the answer is that there has been so much learned about preparation. Balloons have obviously come to be far more superior than they were 110 years ago. And we have a lot to learn about which patients we can worry about and which patients we should not worry about after a drug-coating balloon. And that's really the central question for me going forward. I think that's all learnable. And I think there's a lot to be gained by looking carefully at what the differences are for people that do need to come back. But it's interesting that the pathology after angioplasty still is an enemy for you. And how to get around that and make that so that when you send the patient off back to his or her room, you really don't have to worry at all. That's going to be the central issue having to do with how much these drug-coated balloons will or will not really be part of the armamentarium in the long run, I think.
I think it's spot on what you're saying, Dr. Block. I mean, I think that is the U.S. Resistance to this strategy. I think it was, I grew up with my old man being in the early days of angioplasty and him rushing back in like all you guys did to do these cases in the middle of the night with perfusion balloons and everybody acutely closing. It was sort of like my big fear was the same thing. But when you look at this, like it seems, and this is what we're going to propose at Epic this year, that you're fortunate you're coming, and I know you had a huge correspondence and early experience with Dr. Grunzig. I think you were probably one of the first out of everybody in the U.S. to embrace it. And so, I think if you look at this, the DAPT has made a huge difference. The type of dissection that you're left with behind if you don't have staining in the wall after the contrast clears, so type C or less. If you have an IFR that doesn't change after 5 minutes, so if you put a pressure wire down and it holds and it stays there, and then angiographically, if you let less than 30%, residual stenosis, if you have those 4 criteria, that's what we're proposing to start out with. We're saying let's measure these 4 criteria. Let's set up a multi-center database that we can track patients that have this over the next year and see what we get when we get 2,000 patients. If we have those 4 criteria and none of them acutely closed, then maybe we can extend it to including type C dissections, or maybe we can say, other things that we might eliminate. But the DAPT has been huge. And I think, in the modification of the vessel, the way both you and Kuzra were referring to, is if you talk to the European guys, that's like Antonio Colombo and those guys. I mean, they believe very strongly in that. So there's a lot more atherectomy, a lot more cutting balloons, scoring balloons, removing dissection. If there's a stain, they do some cutting balloons there. And so, and I think also don't be afraid to say maybe this just isn't a good enough result and I have to stent it. But I mean, if that's the case, that's the case. But I mean, I think if you can reach those other criteria and show that you have the safety, which is all I care about in the first, 24 hours, then I think we can at least push things forward. I think it is a totally different animal nowadays, and I think all the atherectomy and everything we're doing maybe is going to make drug delivery into the endothelium better because you're going to eliminate a lot of that calcium or modified it. So it's a definite, like you're on the 5-yard line. You got 95 yards to go, but I mean it's an exciting time to kind of revisit, and I think it's going to be really fun when we do Epic this year. Like if you look at the group that we have coming for Epic and Dr. Block's in that group, but it's all kind of the living legends of the pioneers of interventional cardiology, to learn exactly what Kuzra was saying, to learn exactly what Dr. Block was saying is, how do we do angioplasty? What is an acceptable result? I mean, all these look like dissections. If you and you guys didn't IVUS or image back then because you didn't have it, but if you IVUS these or OCT these, I mean, they look like a bomb went off inside the vessel. And so like, how do we use that to help incorporate into like what's safe, what's not safe? Because nobody knows that at all. And they all look terrible. And so like, but you may be able to go back and say, look, these 3 out of 1,000 closed, we have imaging on all these, and these have more medial dissections or so forth. And so we'd have to, it's going to be a process forward. But I will say, like, I'm kind of dazzled at how low the acute thrombosis rates look like they are from the registries from Europe and Korea and Japan. You never know till you have your own data, but but it looks really promising. When you're talking numbers like 2 out of it, like 1,500, like, or 2 out of 2,000, like, and so we'll see. I mean, we're right on the beginning of it again.
Well said. Well said.
All right, so we'll go through these cases pretty quickly. So for our third case, we have a large vessel prox LED. So a 57-year-old male complaining of angina, has a history of CAD with LAD and RCA disease, hyperlipidemia, diabetes. You can see his medications here. His creatinine is 1.3 and his EF is normal. So here we have, as you can see here, prox LED disease. DFR is positive at 0.75. So we ended up pre-dilating the lesion with a 3.0 NC, and then treated the lesion with an DCB. You can see here. What's that? After we did that, the DFR improved to 0.87. These are our pre and post images.
So that was after just balloon angioplasty and DCB of a bifurcation lesion. So this is what we're talking about. If you go back, this is a patient that potentially ends up getting a complex two-stent bifurcation technique with LAD diag, where we were able to just treat the vessel with just a drug-coated balloon following balloon angioplasty, and had a pretty almost normal DFR, which means the vessel is not ischemic anymore. So, I mean, I think just highlights another subset of patient that we can potentially treat is these complex bifurcation lesions just with a drug-coated balloon.
Very common too. I mean, 20% of all the cases that we do are a bifurcation. So, I mean, and it's always been an Achilles heel of restenosis, particularly with the circumflex when it's the left main that you're dealing with. And the Noble data for 10 years would show that PCI for left main disease is equivalent to CABG. So the days of everybody setting off the alarm and panicking because they found a left main and needs to go to surgery should be over in most people's minds if you're paying attention to modern data. But I mean, I think this is interesting. I mean, like, you've got a bifurcation lesion here. That the restenosis rate on this is probably at least 15 to 20% for one of the two branches. If you did a two-stent strategy, and you're walking away here with no stents. And I mean, and so this heals. Come back and look at this, with a photon CT scan in 6 months and it's healed. I mean, I think you've got a really powerful strategy here. And I think we do a good job at Emory of not getting into all this downstream stuff. So you look at the distal diagonal and distal lesions like that. It's really hard to prove that we do anything worthwhile for people with anything we do. And we certainly don't do anything worthwhile with going after that small vessel stuff.
For our next case, so we have a 65-year-old female complaining of exertional shortness of breath. She has a history of an RCA CTO, dyslipidemia, hypertension, creatinine is 0.8, normal EF. So here, if we look at the right, you can see she has a subtotaled RCA with left to right collaterals. You can see here the distal RCA is filling. And so here we pre-dilated the vessel with a 2.5 and a 3.0 NC balloon. We DFR'd this vessel as well, was 0.85 after about 5 minutes, so which Dr. Nicholson was alluding to earlier in terms of monitoring patients after we balloon angioplasty. And so here we treated the RCA with a 2.5 millimeter DCB. These are results after.
So this is, it's a case where if you looked at these angiograms, our guide catheter, just for references, but 6 French, 2 millimeter. So these vessels, if you talk to surgeons or anyone, it may be hard to put a graft on this, right? Like if they go for bypass surgery, she has multivessel disease. But these are cases there, that we're able to, these long diffuse segments that we're able to just treat with drug-coated balloons and let the vessel, over time with flow and with positive remodeling, especially in the setting of paclitaxel. I mean, I think, you're going to see these really nice, results with flow without any stents in the entire right coronary. So I think another example of a very long diffuse segment disease, subtotal, the almost CTO of the RCA that we're able to treat just without leaving any metal behind. So, and we use the physiology to help us kind of figure out if the vessel is going to close. after we do all our balloon angioplasty and the prep work. And so if there's stability in that IFR measurement over 5-10 minutes, we've seen that as a marker that the vessel will really, it'll stay open after drug-coated balloon treatment. We haven't had acute vessel closures using that algorithm, just in our about 40 to 50 cases we've done here at Emory over the last probably 3-4 months. So I think it's just another subset of patients that I think it's really applicable to treat with drug-coated balloons.
And it's
Pratik Khusro here. Do you think after the vessel is prepped and before the drug-coated balloon is delivered, if we do a physiologic study, and if that comes back abnormal, then go ahead and prep the vessel before using the drug-coated balloon? Because I think drug-coated balloon is to deliver the drug, really not to do the angioplasty.
Absolutely. That's exactly what we did here. Yeah. So we ballooned the entire vessel with a non-compliant high pressure balloon, and then did IVUS, and then did physiology. So the DFR here was 0.85. It's very close. I mean, it's hard to get vessels to be completely normal because you have diffuse disease distally, right? But it's almost to a non-ischemic point. We don't treat with a drug-coated balloon until we know we've done adequate prep work, and the drug-coated balloon is just to deliver the drug. And so it's a low pressure inflation just to deliver the medication. You're exactly right, Dr. Young.
Yeah, I'd add to this too, like, this is a CTO of the right coronary. Like, we're doing close to 450 CTOs a year at Emory, which is, the most in probably the world, but at least the country. And so these are very challenging cases. The national average success on crossing these and being able to open them up is around 55%. We hover around 93%. So we're in multiple registries that show that. But this case, just when people send people for surgery, they send them because there's a CTO, and about a third of these cases will go to the operating room and a surgeon won't be able to put a graft on it. So they went for, because they had a CTO and they don't get a bypass on the CTO vessel at all. And then the 65% or so that do get a bypass on the vessel, if it's the circumflex to the right, which is going to be 80% of the time, the patency rate at 1 year angiographically in multiple surgical follow-up trials on those grafts on a CTO vessel, not just any vessel, but a CTO to the right of the circumflex, the patency rate of that at 1 year is around 20%. So that means 80% of those grafts failed in the first year. So a third of them didn't get a bypass on the vessel that you were worried about, and 80% of the ones that did no longer have that bypass working. So, it's a little different here with John Puskis and some of the guys that do all arterial conduits, which is a super strategy and a real advantage here at Emory. That's a different animal if you put an arterial conduit on it, but a venous conduit on a totally occluded circumflex or a totally occluded right, 20% of them are going to be open in a year. So, we can talk about how bad bare metal stents were and everything else, but they were better than that.
No, I think your comments, it's John Puskis, I think your comments about arterial grafting are very apropos. It's a privilege to partner with such an extraordinary interventional cardiology team and try to bring coronary surgery up to that same world-class level. I'm enthusiastic about the drug-coated balloon concepts because they're likely to be more successful in my mind than leaving foreign material behind in the coronary artery, as you and others have said this morning. Also, because if they don't work long term, we have more options for where to place an arterial graft. As you know, there's lots of randomized trials that would suggest that very complex coronary disease is better treated with coronary surgery than multivessel stenting. But the drug-coating balloon concept is a different idea. And I think it's a very interesting one. The concept in the past that, this patient can have multivessel stenting, and if that doesn't work, we'll go on to bypass surgery. That concept has been espoused in the past as if the risk applied at the beginning of the survival curves, but of course it doesn't. Those survival curves are derived from original assignment to either PCI or CABG. And part of that is because CABG is less effective after multivessel stenting. We don't know whether it's more or less effective after drug-coated balloon that might fail in a multivessel setting, But it seems to me intuitively obvious that I, as a surgeon, would have more options to serve your patient in the event that multivessel drug-coated balloon therapy fails than I would in the setting of multivessel stent therapy with full metal jackets and multiple vessels. So as a coronary surgeon, this seems intuitive to me that it ought to work better than stents, and also intuitive to me that if and when it doesn't work for an individual patient, we'll have a better second plan, a plan B.
I think it's well said, John. I mean, I think I mean, all arterial conduits and the work that you've done is just, I mean, not everybody knows. Like, if you go to STS, I mean, he's pretty much renowned as being the best bypass surgeon maybe in the world. And so, like, we have a completely different option here that you don't have everywhere else. And so for me, like, all arterial conduits and the work that Mike Halkus has done with robotics, I think is a different animal for us. And so, I mean, I think there's also a lot of neat kind of synergy that we'll be able to explore uniquely here that you don't have other places that can do this complex kind of revascularization from both sides of the spectrum. But I think, the thought that this will be, synergistic with bypass, because these are going to fail, right? I mean, like, you're still going to have a certain percent that are going to restenose no matter what you do. And so you're going to end up with these scenarios where you're going to have to use sort of complementary strategies. And I think it'll be fun to explore as we go, because it's such a beginning of a new paradigm. So go ahead, let's finish up there.
All right. And then our last case, calcified large vessel disease. A 67-year-old male complaining of exertional angina, shortness of breath, had a CT that showed CAD. Creatinine is normal, EF is normal. Here we can see the right's diseased and calcified. Left is also diseased and calcified. So here we use rotational atherectomy with a 1.5 burr. See here us treating the proximal vessel. This is pre and post rota. Still see some residual calcification and stenosis, but does look better. So the lesion was dilated as we normally do with a 2.5 and 3.0 NC balloon. We did DFR, it was about 0.75 after 5 minutes. So we ended up stenting the proximate portion with a 3.048 stent, and then we treated the mid-to-distal disease with a DCB. And so here you have our pre and post images.
And this is a surgical turn down as well, right?
Yes, this was a surgical turn down.
That's a nice result. Sure.
Just another example of kind of a long diffuse disease, not doing a full metal jacket. I mean, leaving an option for bypass down the road if needed. But I think, just focal stenting that proximal disease area and treating the rest of the DCB.
All right. So I'm going to go over the data, but for the interest of time, I'm going to be a little bit quick. Pause me if you have any questions. So, as we showed, the application of DCBs is 4 ways. So we have instant restenosis, small vessel disease, bifurcation lesions, and de novo coronary lesions. And so one of the earlier trials that looked into DCBs in Europe was the ISAR Desire 3 trial that looked at instant restenosis. And you can see here for the first year, the outcomes of DCBs versus plain balloons and DS versus plain balloons were pretty equal, and they were both superior to plain balloons. That didn't carry on for the following years, up to 10 years. And so with more trials, we had the more important trial, the Agent IDE trial, that looked also at ISR in the United States. Emory was a big participant of this trial, along with Dr. Nicholson. And so we had 600 patients. We had 2-to-1 paclitaxel coated balloons versus plain balloons. And you can see that the target lesion failure was about 17.9% in the paclitaxel coated balloon, as opposed to the uncoated balloon was 28.6%, with a difference of 10% between them, and the hazard ratio was 0.59. And so this was a large trial, 40 centers participated in. This was pivotal in getting the paclitaxel coated balloons from Boston, the Agent balloon, FDA approved. And that's what we've been using the last 2 years since. These are the time to curve charts. You can see that the target lesion failure, there's separation early on, and that maintained the paclitaxel coated balloons. And these are the individual components of that. And there was mostly statistically significant except for cardiac death. Moving on, Basket Small looked into DCBs for small vessels in Europe. There was also a subgroup analysis for high-risk bleeding patients that participated in this study as well. And you can see that the MACE up to 12 months was no different between the drug-eluted stents and the DCBs after 1 year. No significant difference between them. And these are the individual components as well. There was not any statistical significance between DCBs and DS and the treatment of small vessel disease. Interestingly, there was not a significant bleeding difference between them too, but this was one of the earlier trials that looked at this. Moving on, the Picoleto trial was another trial that also looked at the treatment of small vessel disease with drug-eluted with drug-coated balloons. And so it pitted drug-coated balloons versus DES, and you can see that the in-lesion lumen loss was better in the drug-coated balloons after 12 months than it was in the DES, and it was non-inferior first of all, but it also met superiority when looking into this trial after 12 months. And there was no significant difference in MACE between the DES and the DCB after 12 months. This is the 3-year data that came out, and interestingly, still there was no significant difference between DES and DCBs in all-cause death and cardiac mortality. But what really shines over here is the vessel thrombosis. There was essentially no vessel thrombosis in the DCB arm, and that's what drove the MACE down after the 3-year data. And again, this is looking at small vessels, so there was no lesion treated, no vessel treated that was greater than 2.75 millimeters. DCBs and bifurcations, Dr. Sandacera and Dr. Nicholson talked about this a little bit earlier, but this is where, DCBs can shine as well in terms of, instead of having a lot of metal and creating a neocarina and having the side branch, especially if it's a circumflex, have high stenosis rates. We can have a leave nothing behind strategy where we treat both vessels, the main branch and the side branch, with the proper preparation, and then treat them both with drug-coated balloons. An alternative strategy is to stent provisionally the main branch, and then do a drug-coated balloon treatment for the side branch if it was pinched by the stent. And what we do know right now is that paclitaxel coated balloons with a bare metal stent strategy was inferior to newer generations of drug-eluting stents. However, we have some data supporting the use of paclitaxel coated balloons with the new generation DES, and we still are looking into data for just leaving nothing behind and doing only drug-coated balloon strategy. And this is where a lot of our work in the next coming months is going to come with with all the data that we're collecting and how we're treating these lesions, and with the upcoming EPIC event that we're going to have in April. And then this is one of the meta-analysis that looked at bifurcation lesions, and you can see there wasn't benefit in the earlier months, but with all major cardiac events after 9 to 12 months, this is where potentially we're going to have benefit from having treatment with DCBs as opposed to non-DCB groups of patients. Finally, we can mention over here the Alliance Registry. This is a pretty remarkable work that was done in Japan. And you can see that these patients, 1,500 of them were treated with DCBs alone and with a DS only if needed, as opposed to a hybrid strategy. And these are real patients. I mean, we're looking at patients, 10% of them had STEMIs, a lot of them were diabetics, 20% osteal lesions, 25% bifurcation lesions, 5% CTOs. And a lot of these patients were calcified. Half of them had a significant calcification, and 10% of them required rotational atherectomy. And these were long lesions as well, and 25%. So this is the real world over here. And you can see that the outcomes of target lesion failure after 1 year was remarkable, of only 4.7%. So, that was pretty significant. Now, this is not a trial in the sense that a randomized control trial, but this is a real world experience registry that we had remarkable outcomes from.
Yeah, very low thrombotic events if you look at that. So for us, I think it's a great recap of the data. So this is what the registry that we're putting together's purpose is. So we're going to basically in April do EPIC, and I'll just flash. Do you have that EPIC slide?
Yeah.
Skip to that, yeah. too much data. Yeah, so this is what we're doing, which should be like extremely interesting, exciting. So we were fortunate enough, since what Dr. Douglas and Dr. King, and Dr. Block, and everybody had done here in the past, we have the history here, and so we're basically doing Epic kind of like Brunswick did it back in the day. And so we invited the faculty, and if you look, like everybody that's not an interventionist on the call will know who all these people are, but I mean, these are basically like the pioneers of the early days of interventional cardiology, who heavily weighted towards the Emory crowd. A lot of these people trained at Emory or spent time at Emory or worked here, but a really remarkable crowd. And then also mixed in with kind of the, 3 or 4 thought leaders in the United States in the drug-coated balloon era, and 4 or 5 of the top leading people that lead the drug-coated balloon trials in Europe. And it's a remarkable group. But the point of the group to get together is we're going to open it up to the general interventionists that want to come. We have about 250 seats that we can have, after we have the faculty there. But the point of it would be a working conference. And so Tanvir Rab, who's been big in the European Bifurcation Club and really big with working with the drug-coated balloon end of things as well, is helping with Yasser, one of our fellows, to kind of write a living white paper that's going to be sort of evolved as the conference goes on. So we'll have a consensus white paper to put forward at the end, and then establish that registry that for us had shown you that we would be able to do both at Emory and at multiple centers, and kind of stick to adhering, criteria that we're going to find these 4 criteria. And if you meet those 4 criteria, we're going to leave it as standalone and sort of show what Dr. Block brought up. Do they acutely close? Are they good? And what is the target lesion failure rate? So we'll have follow-up at 3, 6, and 12 months of follow-up as well. So it's an exciting change. I mean, I think the whole world of PCI is going to change dramatically. I think that for some reason, and I think it was maybe what Peter was saying earlier, there's going to be some U.S. resistance to this, and I think somewhere we're going to have to be the ones to show that it is safe and it's effective, and I think we're right at the epicenter of that. So it'll be a fun year coming up, and excited to see the cases. So thanks, Javier, and for us for doing all the work. Pradek does all the work all the time. So, but I think appreciate any added questions or thoughts that people have on what's going to be a definitely change in strategy.
Just one comment. Thank you very much for mentioning. We're also trying, I think, to have an international imprint for Emory. That's very important. I think Dr. King, Bill, and I were invited to the first ever drug-coated balloon club next week, this coming week in Berlin. But it's very important for us to have an international footprint, so that we can have international collaboration with whatever I do and we do over here. And very important to expand the image of Emory as the go-to place for drug-coated balloons in this country.
Absolutely. All right, Pooja, thanks for having us.
Thank you. Thanks so much. And thank you for staying on time despite 4 cases. That's amazing. So thank you. I'll see everyone next week.
The preceding program is copyrighted by Emory University.